Clinical algorithms for choosing psychiatric medication, the types of treatment in the vast majority of psychiatric cases. Once a condition crosses the threshold from moderate into severe, medication becomes the most effective treatment available. We categorize these treatments into two distinct clinical scenarios. New treatment, for a patient who has never been treated or has been off medication for over 1 year. Continuing treatment, for a patient currently on a medication regimen. This includes patients in remission, maintenance, or those with residual symptoms that the patient finds unacceptable. The hierarchy of choices treatment must strictly match the diagnosis. Once that is checked, we follow a specific hierarchy of evidence to optimize the treatment outcome. Only when all the options in the first group are exhausted, it is okay to go to the next group. First choice, FDA-approved medications for that specific diagnosis. Second choice, off-label medications, legitimate indications supported by randomized double-blind placebo-controlled studies but not submitted to the FDA for the purpose of approving a medication for a certain condition. Third choice, indications supported by lesser evidence, open-label, cohort studies, case reports, and others. Only after all higher-tier options are exhausted it is owed to move to a lower tier. The 5 types of medication change. In psychiatry, there are only 5 possible adjustments when it comes to medication regimens. We do not guess. We follow a rational strategy based on the patient's response. Increase, the most rational strategy for persisting symptoms. It has the lowest risk of making things worse. It will either help or do nothing. Decrease, reserved almost exclusively for managing side effects in a patient who is otherwise benefiting from the medication. Add, used only when the current medication provides some benefit, but is already at the maximum dose or the maximum tolerated dose. Replace, the only rational option if a medication is at maximum dose or maximum tolerated dose and provides zero therapeutic effect. Change timing of the dose, used to mitigate side effects, for example, moving a sedating dose to the evening. Selection and the lag time between change and effect. How do we choose the specific drug? Historical success. If a drug and dose type at a certain dose worked in the past, we return to the same. Strategic side effects. If no medication treatment history exists, we choose an FDA-approved drug whose side effects could be of benefit to the patient, for example, a sedative drug for an agitated patient. Managing expectations. We must break with the classic medical model, which is, we are healthy, then we get symptoms, we take a medication, in days or weeks symptoms are gone, so we stop the medication and another stretch of time of good health follows. In psychiatry, the pattern of response to treatment is different. Onset of therapeutic effect. Unlike an aspirin, which needs 1/2 to 1 hour until it has an effect, most of the psychiatric medications may show slight improvement in 2 to 3 days, but require 6 to 8 weeks for the maximum effect. Duration of treatment. We do not stop when we feel better. Remission requires at least 6, but even better 12 months of consolidation of gains before any medication change should be considered. For many, treatment is a decades-long necessity to continue benefiting from the therapeutic effects. Compliance through empowerment. Compliance is the #1 predictor of a positive outcome. To maximize compliance, we follow a shared decision-making model. Offer 2 to 3 options. Present to the patient the pros, cons, and probabilities of side effects for each option. Patient as appraiser. The patient is the only one who can decide if a therapeutic gain is worth putting up with a specific risk for a specific side. They are the ones to attach value to each of these aspects of treatment and put everything in balance to make a judgment whether they accept one option versus another. This reduces resentment if things do not go as planned and increases adherence to the medication. Contingency planning. Establish what-if protocols. Mild scenarios. If nauseous, take with food. Emergency scenarios. If a rash develops on lamotrigine or fever/stiffness occurs on a neuroleptic, stop the medication and go to the ER immediately. In conclusion, when these rules, diagnosis matching, rational adjustment, side effect handling strategies, and patient's involvement in medication choices are strictly respected, we move away from a trial and error approach and toward a predictable, successful clinical outcome.